Okay, this is chapter 16. We're taking a look at the endocrine system. And so let's go ahead and start out by sketching out some of the pieces of the endocrine system. So we first start off with what the endocrine system does. So the job of the endocrine system is to produce chemicals, hormones essentially, and their job is to regulate the activities and the functions of all the other organs. And so the endocrine system and the nervous system typically are working very close together to maintain homeostasis in the overall functionality of the body. And so when you take a look at the endocrine system, you can break it up into several different organs. We're going to cover these one by one. And so I don't want to spend too much time here, but you have your hypothalamus, which is actually a region of your brain. And it's connected to the pituitary, which is sort of the master gland. And then in response to the pituitary are a whole spectrum of different types of glands throughout your body. For instance, you have your thyroid gland, your parathyroid glands, which are in the neck region. You have the thymus, which is actually just on top of the heart. The adrenal glands, which are sitting on top of the kidneys. The pancreas, which is a type of gland. And of course, your testes and ovaries, which are responsible for regulating all the hormones associated with your reproductive system. So let's go ahead and take a look at the different types of glands and the activities of the glands that we have, because we're talking about glandular activity. So we have exocrine and endocrine glands. And basically what we mean by this is essentially it's a designation that's essentially designed to sort of describe how it is that you actually secrete or submit your hormone to the rest of the body. For instance, an exocrine gland will secrete their hormone products into a duct system, and an endocrine gland will not. It'll dump it directly into the bloodstream, and it'll deliver it and disperse it throughout the body using the cardiovascular system to do that. Now, generally speaking, whenever you're dumping a hormone into the body, the hormone is designed and set up so that only the target cells will respond to that hormone. And the way they respond to it is they have a receptor on the surface, typically, of your target cell. So if this is your target cell, then there's a receptor that's specifically designed only for that hormone, kind of like a lock and key sort of a strategy. So the hormone itself will be the only thing that can bind to that receptor. And then when the hormone and receptor bind together, then that kind of unlocks the communication between those two, between the hormone itself and the cell, the target cell, who's supposed to be doing whatever job that it's being told to do. Now, both nervous and endocrine system use chemical signals, like we mentioned before, neurotransmitters in the nervous system. And of course, these tend to be faster than in the endocrine system. And then, of course, hormones in the endocrine system, these tend to take a little bit longer. So the endocrine system is designed for slower, kind of long-term, long maintenance kinds of activities. And the nervous system is typically associated with quick responses and reflexes and things like that. Both systems are subject to feedback mechanisms in terms of regulation to control them. And so this is kind of what it looks like. So the action of a neurotransmitter versus a hormone. So here you can see, and this is just recapitulation from a previous chapter, the neurotransmitters, which goes into the synaptic cleft. And then it communicates with the target cell, as opposed to the hormone. In this particular case, you've got a hormone being secreted by the pancreas, and that's being dumped directly into the bloodstream, where the, in this case, insulin will respond and bind to the insulin receptors that cells have, your liver cell in particular, in this particular case, and then that'll communicate whatever message that particular insulin is telling the liver to do. So it's basically a type of communication. So the hormones are communications between cells and between body parts, and that's basically how this all works. So essentially, you're orchestrating and regulating how cells are operating, what they're doing, when they're doing it, and how much they're doing. So it's a regulation of all these different activities that are going on. Now, generally speaking, because it's a long-term sort of a thing and it's a systemic sort of a thing, generally, most hormones activities, that is to say their fundamental action, is a little bit further away from where they're secreted. So oftentimes they're secreted from a gland and then they're delivered to some far-flung region of the body. So it's a little further away. So their point of action is a little further away than their point of secretion. And then typically what will happen is it affects the metabolism of the cells that bind to them, essentially the functions of the cells that bind to them, and it tells the cells what to do. So here's an example of a capillary that's bringing a hormone to the tissues, and this hormone will basically move out of the tissues and it'll bind to specific receptors that you find on these target cells. So here you can see, here is a target cell with a receptor, but the receptor is designed to fit a different molecule. So there's no communication between this cell and the hormone. But you can see these receptors fit the hormone shape like a lock and a key. And so when the cell binds to that hormone, then it basically receives the message and it's able to basically change its functionality and what it's doing in order to essentially do its job according to what the body is telling it to do. Okay. So generally speaking, when you take a look at hormones, you have different types of hormones. You have what we refer to as like local hormones, basically, that are simply going to neighboring cells. So they're not going to very, very distant areas. That is to say, they're not carried in the bloodstream to the far-flung regions of the body. So a good example of those are things like prostaglandins, which will oftentimes increase fever. Also, growth factors can be very local in nature. So they're just targeting specific regional areas and regional activities. Pheromones basically are types of hormones that will influence the behavior of other individuals. For instance, animals in particular rely heavily on pheromones to either mark their territory or to attract their mate. So you can almost think of this as sort of like a natural smell, if you will, in some sorts. But this is a hormone that's designed to communicate something to other individuals of the same species. We also produce pheromones because we are kind of like mammals. Only it's a little bit different for us. So most animals are that's how they communicate. They're communicating with each other through their pheromones. Whereas we have a lot of different other ways to communicate, not just with our pheromones, but we still have pheromones as well. It's just not as pronounced in us as it is in other animals. Now, when you take a look at the endocrine system, so this is just basically a kind of a table, if you will, an organization of the different structures. And I want to go through this fairly quickly because we want to dig into the nitty gritty of this here in just a little bit. But these are basically the glands and essentially what they release and where their targets are and what they do. So the hypothalamus, for instance, typically will be starting the whole thing off. They'll be releasing what's called hypothalamic releasing hormone. Its goal is to go to the pituitary. So the hypothalamus is talking to the pituitary and give the pituitary instructions. And its job is to regulate what the pituitary gland is doing. Now, the pituitary has a couple of different regions to it. It has what's called the posterior pituitary, which is releasing a hormone called antidiuretic hormone and oxytocin. Antidiuretic hormone in the kidneys is going to be what stimulates water absorption in the kidneys, so it allows you to retain water. And oxytocin is typically associated with muscle contraction, especially in the uterus during birth. Now, in the anterior pituitary, you have a little bit more going on. So you have the thyroid stimulating hormone, who will go to the thyroid and regulate thyroid activities. The adrenocorticotropic hormone, or ACTH, will go to the adrenal glands and will stimulate the functions of the adrenal cortex. Gonadotropins, like, for instance, FSH and LH, which are follicle stimulating hormone and luteinizing hormone, these go to the gonads, basically the reproductive organs, and they're regulating the activities of egg and sperm production for the production of our gametes. Prolactin specifically will target the mammary glands, and that's basically regulating milk production in new mothers. Growth hormone will go into different types of tissues, soft tissues like muscle and bone, and they're stimulating cell division and bone growth. And then melanocyte stimulating hormone will basically move toward melanocytes in the skin. And generally speaking, it will oftentimes regulate pigment deposition, typically, for the most part. Now, the thyroid gland, which already got target, is now going to be targeting something else. For instance, the thyroid gland is going to be receiving the message from the pituitary, and then it's going to be making what's called the thyroid hormones, which is T3 and T4, thyroxine and triiodothyronine. And so this goes to all the tissues, and its basic function is metabolic rate management. It also makes calcitonin, which is designed for lowering blood calcium in the blood. Parathyroid hormone is coming off of the parathyroids. This is also going to be targeting bones and kidneys, and it's going to be raising blood calcium. The adrenal gland has two different regions, the cortex and the medulla. The cortex is going to be making cortisol or glucocorticoids. This goes to all tissues. This regulates how you use and break down blood glucose. Mineral corticoids like aldosterone, which is basically going to be targeting the kidneys, is associated with the reabsorption of sodium. And the sex hormones, oftentimes the androgens, testosterone, for instance, is going to be going to the gonads, skin, muscle, bones, which is going to help stimulate and regulate secondary sex characteristics, especially in males. Now, the adrenal medulla is going to be producing the adrenaline, so epinephrine, norepinephrine, which oftentimes will have their primary targets in cardiac and muscle cells. And these guys are essentially going to be focused on your fight or flight response. So it's going to increase a lot of different types of physiologies in your body as part of your fight or flight response. And then, of course, the pancreas is producing two different types of hormones. Insulin, whose job it is to regulate blood glucose by lowering blood glucose, and glucagon, which is the opposite. So that's going to be raising blood glucose levels. And then, of course, in the gonads and the reproductive organs, you're going to have the testes and the ovaries, which are producing testosterone and estrogen, respectively. These are going to the reproductive organs, and they're going to be regulating all of the sex characteristics of males and females. And then the thymus is going to be making the hormone thymosin, which is responsible for developing T cells, and that'll basically mature the T cell lymphocytes for your immune system. And the pineal gland is going to be producing a hormone called melatonin, which targets your brain, and this basically controls your circadian rhythms and also your sleep cycle. So hormones basically can do a lot of different things, and so we use them in a lot of valuable processes. For instance, they can stimulate the uptake of certain things like glucose, for instance. They can alter the structure of a target cell. They can influence their metabolism. They can do a lot of different things. There's a big range of the activity of hormones. Now, with a hormone structure, we can actually categorize them by structure. So they're structured differently. So some of these hormones are peptide hormones. That basically means that they are basically proteins or glycoproteins or some sort of a modified amino acid. And so, for instance, your growth hormone is a protein that's secreted by the anterior pituitary, right? So that's an example of a protein hormone. You also have steroid hormones. For instance, these typically are derived from cholesterol. And so these will have several different types of steroid hormones, but they're all basically derived from cholesterol. And so those are different types that you have there. A lot of them are peptide hormones, and they can have a lot of different types of actions. So, for instance, when epinephrine, which is one of your adrenalins, binds to a receptor on the muscle, basically what's going to do is it's going to facilitate ATP production so that you can have energy to contract your muscles. And what will happen is the first thing that's going to happen is a molecule called cyclic adenosine monophosphate, so it's CAMP, is formed. And then this activates what's called a protein kinase enzyme in the cell, which basically activates other enzymes. So let me explain what a kinase is. So a kinase basically is any enzyme that phosphorylates another protein and either turns it on or off. It's like an on-off switch. So the presence of a protein, so phosphorylating a protein, will either turn it on or turn it off. And so that's what a kinase does. And then what happens is when you turn on this first kinase, it creates a cascade of kinases that sort of turn other molecules on. This is what's called an enzyme cascade. And so these oftentimes will be what's created in response to a hormone. So generally speaking, the peptide hormones, as they come and interact with the cell, they never get into the actual target cell. What they do is they relay the message to the cyclic AMP. So ultimately, this first messenger, which is a hormone, will relay that to what's called a second messenger, which is cyclic AMP. So this is basically the guy who picks up the message and then runs with it through the cell. This is called the second messenger. So you can see here, you have the original messenger here. This is your first messenger who basically binds to the receptor, and then this message is communicated, and basically you get the production through adenylate cyclase of cyclic AMP, which then relays the message to the interior of the cell. So it's just like if I were to send an email to, like, all the managers, and I would just say, take this message and then, send it to all of your departments. So, basically cascade it on down. So they're taking a message from me, and then they're relaying that message to their own individual work groups. And that's kind of what happens with the second messenger. It takes the original message from the hormone, and then it relays that to the rest of the cell and everybody who needs that message in the cell so they can do their job appropriately. So when you take a look at steroid hormones, you have several different types, and they have several different functions. Remember, they're all coming from cholesterol. They're all derived from cholesterol. And when you take a look at steroid hormones, you basically have three places where they're coming from. Number one is they're coming from the adrenal cortex. And there's one layer in the adrenal cortex specifically they come from, or the ovaries, or the testes. Thyroid, that's where the steroid hormones are coming from. So steroid hormones, because they're lipids, they don't bind to a plasma membrane receptor. Because they're hydrophobic, they're able to cross the plasma membrane freely. So that's because they're lipids, right? Because the membrane is a lipid layer, right? The phospholipid bilayer. And so basically, because the steroid is a lipid, it basically goes inside, and its receptors are in the inside, either in the nucleus or in the cytoplasm. Now, the thyroid hormones are kind of a different type of a structure. So these are what's called amines. They're kind of similar to steroids, but they're not technically steroids. Okay. So inside the nucleus, when the steroid hormone binds to its receptor, then what happens is it'll bind to DNA and it'll turn on certain genes. And this is basically what it does. And so what happens is when it turns on these genes, then it'll make copies of RNA of these genes, messenger RNA. And this will go to ribosomes for proteins to be made. So essentially what happens is the steroid hormone receptor complex turns genes on, and then allows them to make the proteins necessary to do whatever job it is that you need to do. Generally speaking, when you take a look at a steroid hormone, they're a little slower than peptide hormones because it takes a little bit of time to make a new protein. It's not an easy process, so you got to go through a lot of different steps to make a new protein that's functional and ready to go. So for instance, in this protein hormone one, the proteins are already there. You just have to turn them on. So it's a little faster with the proteins as opposed to with the steroid hormones, because you have to make them from scratch with the steroid hormones. However, because of this, they tend to last a little bit longer, and they're more enduring than, say, the protein type of hormone situation. So this is kind of what it looks like. So here's your steroid hormone. Because it's hydrophobic, it'll be able to get through this hydrophobic membrane, passes through easily, no problem whatsoever. And then it'll bind to its receptor. So the receptor can either be in the cytoplasm, or it'll go through a nuclear pore and bind to its receptor inside the nucleus. And then this becomes what's called a transcription factor. Basically, it'll bind to the DNA and turn the DNA on, and this will activate the production of mRNA, which will then be exported out and then attached to a ribosome to make your protein. And so the protein then can get to work and do its job. Okay. So let's go ahead and take a look then at the hypothalamus and the pituitary and start kind of working our way through this list. So first of all, the hypothalamus is kind of the link between the endocrine and the nervous system, because technically the hypothalamus is part of the brain. And as a result, it tends to regulate the internal environment of the body. It's part of the autonomic nervous system, which is kind of that automatic part of the nervous system that sort of controls systems that are on autopilot. It is the major thermostat when it comes to your body. So it's controlling your body temperature. It also is a major player in water salt balance as well. And so its job is to regulate and kind of keep tabs on body temperature, salt-water salt balance, but it's also going to be the boss, if you will, of the pituitary gland. And so it controls what the pituitary gland does and how the pituitary gland behaves. So the pituitary gland is connected to the hypothalamus by a stalk. And so it has two different portions, as a posterior portion and an anterior portion. So basically a front half and a back half. And in the posterior side of the pituitary, there are what's called neurosecretory cells. These are basically neurons that secrete a hormone in this case. So those neurosecretory cells, these guys are located in the hypothalamus. They produce the hormones ADH and oxytocin. And what they do is these hormones will then pass into the posterior where they're stored. And so you keep these guys ready for release when needed. So the pituitary doesn't make ADH and oxytocin, the hypothalamus does. The pituitary simply just stores them and releases them when it's necessary. So this is kind of what it looks like. Here's your pituitary. You can see you have the anterior side. So this is the optic chiasma. This is the part that's attached to your eye. Your hypothalamus is this lower region over here. And you can see here you have different nuclei. You've got 14 different nuclei in the hypothalamus. There's a couple of them that we're interested in, one of which makes oxytocin. The other one makes ADH. And so you can see these neurosecretory cells, these kind of long green cells that basically wind their axons all the way into the posterior side of the pituitary, and then they just hang out there. They're kind of like interfaced with the capillaries. And so these guys will be holding oxytocin and ADH, and they'll just be waiting to release those hormones into the bloodstream when necessary. In the anterior pituitary, you'll notice you've got a whole bunch of glandular cells that will be making all the other pituitary glands. So for instance, when you have ADH release, you're going to be going to the kidney tubules and you're going to be acting on water retention at the kidneys. So you're going to retain your water instead of urinating it out. Oxytocin, on the other hand, is going to be associated with the smooth muscles of the uterus for contraction during labor, during a labor cycle, or also the mammary glands as well for contraction of small musculature there. So when you take a look at the hypothalamus, there's, like I said, several different types of regions of the hypothalamus. Some of these neurons are designed to sense the water-salt balance. So for instance, if the blood is too concentrated, then what's going to happen is ADH is going to be released from the pituitary, and then it's going to cause more water to be reabsorbed into the kidneys and capillaries. So this basically results in water retention. You're not going to urinate it out. So as the blood becomes diluted, then you stop making ADH, so you're not going to release it. And then that's going to allow you to urinate out the water to kind of reduce your blood volume. So this is all subject to negative feedback. For instance, the effect of the hormone, which is to dilute the blood, acts to shut down the release of the hormone. So the actual dilution or the effect of the actual fix is going to turn itself off. So it's kind of like a fail-safe. Okay. Now, in diabetes insipidus, basically, this is a situation where you have the inability to produce ADH. And so as a result, you tend to release large amounts of urine, lots of water loss, because you're not retaining it. And so you can also lose a lot of ions along with that. So you get dehydration, ion deficiencies. And then in order to fix that, you would have to administer a medicated version of ADH to restore that activity. Now let's go ahead and take a look at oxytocin. So in oxytocin, basically what's happening is you're creating uterine contractions. This is typically during childbirth or the letdown mechanism of breastfeeding. And so the more the uterus contracts, then the more the nerves in the uterus will signal to the hypothalamus, causing the oxytocin to release. So typically as the baby suckles while breastfeeding, nerve signals from the breast will basically go to the hypothalamus, and it'll stimulate the production of oxytocin. And then that causes more breast milk to be released. So you can see then that it's a responsive system. The more the baby suckles, then the more stimulation that the mother gets to release more milk. The idea is that you're breastfeeding, so therefore you need the milk, and then it releases that. So the release of oxytocin is actually a type of positive feedback. The reason is because the stimulus reinforces the oxytocin release, right? So the stimulus that first happens, basically it keeps increasing its own release. So the more oxytocin you have, the more oxytocin you signal. So the nerves signal back to release more oxytocin, which generates more oxytocin, which then stimulates the nerves to stimulate a reinforcement of oxytocin. So ultimately, the positive feedback will terminate oftentimes due to some external event. For instance, the baby is born. So you don't have the physical strain anymore. And so that loss of physical strain on the body will basically reduce the signaling of the oxytocin loop, and then it'll stop producing. For the anterior pituitary, you have a lot of different types of hormones going on. First of all, coming from the hypothalamus are what's called hypothalamic releasing, which is instructing the anterior pituitary to release hormones, versus hypothalamic inhibiting hormones, which is basically telling the hypothalamus to not make hormones. And so these will pass from the hypothalamus into the anterior pituitary by way of what's called a portal system. And I think we talked about portal systems before in the cardiovascular system. And so ultimately what's going to happen is, for instance, with the thyroid, using the thyroid as an example, so the hypothalamus is going to release what's called the thyroid releasing hormone. This basically stimulates the pituitary to make thyroid hormone. Or it can release the thyroid inhibiting hormone, which will shut down the pituitary from making or stimulating the thyroid response. So the TRH will stimulate the pituitary to make the thyroid stimulating hormone, and the TIH will inhibit the thyroid stimulating hormone. So this is kind of what it looks like. So basically, you have these releasing and inhibiting hormones coming in from, so these are these guys here on this side, that are basically going through the portal system, and then it's communicating to the anterior cells, telling them whether or not they should be making or not the particular hormone that they need to make. Now, coming from the anterior pituitary, in response to these releasing and inhibiting hormones, they're going to be making several different types of hormones. So for instance, on the anterior side, you're going to be making one that's called TSH, thyroid stimulating hormone. This will stimulate the thyroid to make thyroid hormones. So that's what it does. Your adrenocorticotropic hormone, ACTH, is going to be stimulating the adrenal cortex to produce cortisol. Your gonadotropin hormones, which is follicle stimulating hormone and luteinizing hormone, these guys are going to be associated with stimulating sex cell production. And so you can see all these different secretions come from the anterior pituitary. So in this case, your hypothalamus is going to be producing your releasing hormone for TRH. It's going to communicate to the anterior portion of the hypothalamus, which is going to stimulate the production of thyroid stimulating hormone, which will then be released in the bloodstream to go to the thyroid, and it'll be telling the thyroid to make T3 and T4. That is the thyroid hormones. As the thyroid hormones build up, what's going to happen is they're going to negatively feed back on the production of thyroid stimulating hormone by repressing the production of TSH in the pituitary. They can also feed back and repress the TRH stimulation. So you can see how this is a negative feedback loop, where the ultimate final product of your pathway, which is thyroid hormone, feeds back in high levels once it gets up to high levels and shuts down its own production because you've already got what you need. So prolactin is also one that's coming off of the pituitary, the anterior pituitary. This is only for milk production in mammary glands. And so that's basically its target. And then, of course, melanocyte stimulating hormone. Basically, this is your skin color changes, and it actually stimulates melanocyte activity. So So it's a depositing of your melanocytes. So growth hormone, which is also coming off the anterior pituitary, is oftentimes referred to as somatotropic hormone. This is basically going to target skeletal and muscular growth. And so it increases your protein synthesis so you can build more muscle and build more skeletal and more bone. It also stimulates the production of a growth factor called IGF-1 by the liver, which also increases growth and development. So you can see growth basically does what it does, what it says it does. It basically increases the growth of your tissues. Now, what about growth hormone? What if we have too much? What if we have too little? So the quantities of growth hormone are typically the biggest during our growing periods. Like for instance, during childhood, when we're growing up, and certainly during adolescence, this is really when it really kicks in, because this is the fastest rate of growth that we experience in our entire life is during adolescence. So we get lots of growth hormone there because we're building muscle and bone. If we don't have enough growth hormone in children in particular, then we're going to get what's called pituitary dwarfism. So we have perfect proportions. That means our arm, the length of our arms and our legs and our torso is in proportion with each other, but we just tend to be small in stature. Okay, this is probably what we're talking about when we look at the pygmy tribe in Africa. Okay, small, but well proportioned. Gigantism, this is basically when you get too much growth hormone in children and you start to get a very large stature. You can have other types of problems because large body does create wear and tear on your body and your systems. Or you can get what's called acromegaly, where you have too much growth hormone in adults. That is to say, it doesn't stop being produced. Usually it stops being produced in your teenage years. But if it doesn't stop being produced and it persists into adulthood, then you're going to start getting long bone growth. You're going to start getting long bone growth cessation. And so your feet and your hands basically become overly large. And so you kind of start getting disproportionate sizes. So this is kind of what it looks like. So this is like a situation where you have a growth hormone, overactive growth hormones. You can see in individuals very, very tall, very large, very massive. Oftentimes they're very unstable because their body's not designed to carry that much size. The overproduction, acromegaly, for instance, is an example where you have isolated enlargement of your limbs. So for instance, here's your normal hand. Here, notice the proportions versus abnormally large joints and things like that. So that would be acromegaly. So notice it's not a whole body thing. Oftentimes it could be isolated areas. Okay, so let's go ahead and start moving through and taking a look at the thyroid gland. So the thyroid gland, this is going to be responsible for regulating your metabolic rate. So it basically controls your sort of basal metabolism. It also controls your calcium homeostasis. And typically when you take a look at the tissue, it's broken up into structures called follicles, which has basically responsible for making two different molecules. One is called triiodothyronine or T3. The other one is thyroxine or T4. And these are so called because they have iodine atoms in them. So for instance, triiodothyronine has 3 iodines in them. Thyroxine has 4 iodines in them. That's the reason why they're called T3 and T4. Now, when you take a look at this, iodine is a necessary component for your thyroid molecule, which is the reason why iodine is a necessary mineral for us. So you have to have iodine in our diet. And if it is lacking, then you simply can't make your thyroid hormones. Basically, if you have low level thyroid hormones, it oftentimes will trigger the response to increase your TSH secretion. And so that'll enlarge your thyroid to generate increased levels of TSH, and that'll give you what's called a goiter, right? And so this is an example of what a goiter looks like. So you can see an enlarged thyroid gland because you're making an abnormal amount of TSH, and that's swelling your gland up. Okay. So the thyroid hormone will increase your metabolic rate, but they typically don't have a target organ. The reason is because they just go after all cells of the body. So they essentially regulate your basal metabolic rate across the board. And so that's kind of what that's kind of what that looks like. So here's different examples of goiters. So this would be hypothyroidism, which would be a lack of thyroid productivity. This would be an ophthalmic goiter, where you basically have an enlarged eye due to thyroid activities or abnormal thyroid activities. So when you take a look at thyroidism in different types of situations, you have congenital hypothyroidism, which is basically something that it happens during birth. So congenital basically means there's some sort of a developmental mishap that happens in those first 9 months of development. And so you have an underdeveloped thyroid at birth. And so because it's underdeveloped, you have an undersecretion of the thyroid hormone. And if you have less thyroid hormone, then oftentimes you don't have the metabolic rate to be able to support normal brain development. And so you start to get intellectual disability as a byproduct, because you don't have enough energy and fuel for the brain development piece. Myxedema is hyperthyroidism in adults. So typically, if you're kind of lethargic or weight gain, loss of hair, slower pulse, lower body temperature, these are sorts of the symptoms associated with that. And so typically what will happen is you just administer thyroid hormones, and that'll usually restore normal function. And so we see that all the time. Exophthalmic goiter, this is hyperthyroidism, oversecretion of the thyroid hormone, basically. Too much of a good thing. And so it's overactive and enlarges, forming a goiter. And so the eyes protrude because of the edema, which is swelling due to water retention in the tissues. Of the eye and the sockets. And so this is oftentimes associated with hyperactivity or nervousness, irritability, things like that. Usually you have to have surgical treatment for this in order to kind of get this sort of calmed down a little bit. So another thing that it does is calcium homeostasis. So calcitonin is going to be a major piece of the calcium homeostasis. So this is secreted by the thyroid gland, and its job is to regulate blood calcium levels. And so when calcium is secreted, then what happens is calcitonin will come in and lower the calcium levels. For instance, calcium is important because it's necessary for muscle contraction. It's also necessary for blood clotting and a lot of other physiological parameters. So you do need calcium in there. And so what happens is calcitonin will basically stimulate the deposition of calcium into the bone so you can store it. And then you can release it later. And so ultimately, when your blood levels are high, then calcitonin will kick in, and then it'll store a lot of that into the bone, and then the blood calcium levels will lower back down to normal, and then the release of calcitonin will be inhibited. So you basically fix the problem. This is what it looks like. So here you can see a perturbation in homeostasis. In this case, your normal calcium blood levels. If the calcium gets high, then what's going to happen is the thyroid is going to secrete the calcitonin into the blood. The calcitonin is going to cause that calcium to be packed into the bone, taking it out of the bloodstream. That lowers the blood calcium levels and gets it back down to normal regulation. On the flip side of things, if the calcium levels get too low, then what happens is that stimulates the parathyroid glands, which are also on the they're not part of the thyroid. They're kind of just attached to the thyroid. They'll secrete parathyroid hormone, which will do the opposite. So basically, this will do 3 things. First of all, this will take osteoclasts and cause them to tear bone down, which will release calcium into the bloodstream, raising your blood calcium. It'll also cause kidneys to basically hang on to calcium to resorb it, leaving it in the blood. That increases your blood calcium levels. It'll also stimulate calcium to be absorbed better with vitamin D in your intestines, which also increases your blood calcium levels. This should bring your blood calcium levels back up to normal. So when you take a look at your parathyroid hormone, it's always going to be released in response to your low blood calcium levels. And so it's going to turn on the osteoclast, which basically breaks the calcium out of the bones and releases it in the bloodstream. It'll activate vitamin D or calcitriol, which is stimulated or secreted by the kidneys. This will cause the kidneys to retain calcium in the bloodstream, so you keep the calcium in your blood up high. And then it'll also it'll also cause the absorption, increase the absorption ability of your calcium as well, so that you retain more calcium in your digestive system by way of your digestive system. So it'll basically bring in more calcium ions from food. So there's 3 different levels that your PTH is working on, and it looks like this. So this is basically your homeostatic curve. So basically your blood calcium levels are going up and then down, and then up and then down, and then up and down. That's your normal homeostatic oscillation. So at the tip is going to be your calcitonin response. So that's to deflect the curve to bring those calcium levels back down. At the trough, you're going to have the PTH response, which is to inflect the curve back up and keep your blood calcium levels in homeostatic balance. So hypoparathyroidism basically is when you have too little PTH. And so this basically will create a huge drop in your blood calcium levels. And so it can also cause tetany, where your muscles will seize up, constant contraction. And so this could create seizures and heart failure. So you definitely want to make sure that you are treated for this. With hyperparathyroidism, this is where you have an oversecretion. And so ultimately, this could lead to a reduction, a dangerous reduction in calcium, which will start to lead to osteoporosis because you don't have enough calcium in your bones to maintain the integrity of your bones. You can also have a ton of calcium go to your kidneys, which could start to amass and start creating kidney stones, which are also a problem. So let's go ahead and take a look at the adrenal glands. The adrenal glands basically sit on top of the kidneys, broken into 2 different regions. You have the adrenal medulla, which is the inner portion, and then you have the adrenal cortex, which is the outer portion. And so there are 2 different functional regions of these particular 2. They're under also nervous control, and they're also under hormonal control. So, for instance, the cortex is under the control of what's called a corticotropin releasing hormone from the hypothalamus, and it's also under the control of ACTH from the anterior pituitary, right? So this we see with these 2 different areas. In the medulla, the hypothalamus will send signals, and they travel through the preganglionic sympathetic nerves. We saw a little bit of that earlier in the nervous chapter, into the adrenal medulla to stimulate them directly. And what happen is they will secrete epinephrine, which is the adrenaline, and norepinephrine, which is noradrenaline, and then they'll basically bring about changes in your body, fight or flight. So if you're getting ready to run for your life, fight for your life, short-term response stresses, this is basically shifting your physiology to be able to run in a stress situation. So that's kind of what it looks like. So in the hypothalamus, you have a nerve that basically will connect directly into the spinal cord. And from the spinal cord, it'll directly connect to the medulla. And this is so that when your brain perceives stress, it can basically go straight to the adrenal glands for your stress response. And those are what's called the sympathetic fibers, those fight or flight fibers. Okay. And then from there, you can basically stimulate the secretion of the adrenal components. Now let's start to take a look at the cortex. The cortex is actually broken into a couple of layers. So the cortex basically has 3 layers called zonas. Zona glomerulosa, which is from the outside in. Glomerulus is the outermost one. Fasciculatus is in the middle, and the zona reticularis is in the bottom. And then in the middle is going to be below the reticularis is going to be the medulla. And so these are like long-term maintenance types of hormones that are being produced. So for instance, the types of hormones that we're going to be looking at here, glucocorticoids and mineralocorticoids. They also have a little bit of androgen or sex types of hormones as well that they're going to be produced. So typically when you take a look at the adrenal glands, you'll see a connective tissue capsule on the top, and then you'll see the cortex being broken into the zona glomerulosa, which is the most superficial piece, and then of course the zona fasciculata, which is underneath that, and then the zona reticularis, which is beneath that. And then beneath that is going to be the adrenal medulla, where you have the adrenalins being produced. And so when you take a look then at the different sort of stress responses, then what's going to happen is, in addition to the neural hookup, the adrenal hookup is going to be coming from the anterior pituitary in the form of ACTH, which basically communicates with the cortex. So the cortex is actually under the communication of ACTH, and ACTH is going to be regulating the mineralocorticoids as they're being released from the adrenal glands to go communicate with other tissues. And so we'll take a look at these. So the glucocorticoids basically are going to be controlled by ACTH, which is released by the anterior pituitary. Their job is to regulate carbohydrate, protein, and fat metabolism. Now, I don't want to get too much into that because it's a big, big story. But ultimately, they're going to be produced by the zona fasciculata and also by the reticular as well. So one that can alter your fat metabolism and kind of create weight gain and things like that. That's the reason why they kind of say it's like you need to manage your stress levels by managing cortisol release. So it can be very wear and tearing on your tissues. So when you release a glucocorticoid, its job is to raise the blood glucose level in two ways, right? So the blood glucose levels so that you can increase your metabolism. So you can do this one of two ways. First of all, in order to get glucose, you can either break down muscle, right, the muscle proteins into amino acids, which are then taken up by the liver, and then the liver will convert the amino acids into glucose. That's typically not something you want to do. Or you can promote fatty acid metabolism, and this spares that carbohydrate piece. So this is the idea. You would rather burn fat than protein. You don't want to burn your muscle protein, right? So that's a bad thing. Cortisone and other types can also relieve swelling, like hydrocortisone and things like that, right? Pain and inflammation. So basically what they do is they suppress the pain and the immunity, but you can also become highly susceptible to injury and infection because you're removing that immune response, that immune presence. So that's the reason why we use hydrocortisone and things like that for different types of low-level inflammation, skin inflammations, and things like that. Now, mineralocorticoids, basically, their job is to regulate ion balance in the body, and they're typically produced by the zona glomerulosa of the cortex. The most important one is aldosterone. Now, aldosterone is going to be targeting the kidneys, and be active in the kidneys, and its job is to promote the absorption of sodium and the excretion of potassium. So what the job of aldosterone is to do is to basically retain sodium in the blood. That creates the necessary osmotic purpose for water to come and chase it. Now, in addition to the aldosterone response is connected to a whole bunch of others. So renin, for instance, is another type of a protein. It's a hormone that's secreted by the kidneys when your sodium levels are getting low. So when renin is produced, it's an enzyme that will convert an inactive form of a protein called angiotensinogen from angiotensinogen 1 to angiotensin, or excuse me, from angiotensinogen to angiotensin 1. Then what happens is angiotensin 1 is converted into angiotensin 2 in the lungs. And then angiotensin 2 is basically going to have a lot of effect on the adrenal cortex, the release of aldosterone and things of that nature. So what we have is kind of a system here called the RAS system, where you have renin basically creating angiotensin, which then will create aldosterone. And the idea here is that you retain sodium, which allows water to enter into the bloodstream from what would have become your urine, right? So you're retaining water. So overall, the net effect is to retain water. So water will enter the blood because it's chasing the salt, and then that'll increase your blood pressure, and that'll keep your blood pressure up. This is kind of what it looks like. So in cases where you have a low, let's do the high one first of all. We haven't actually talked about ANH. I want to go back, talk about ANH first, and then we'll go back, and then we'll talk about that one. So on the flip side of blood pressure, right? So if you have an increased blood pressure, you have your adrenergic hormones, atrial natriuretic hormones or peptides. And these are going to be released when your cardiac cells stretch, especially in your atria. So create a signal that will inhibit the secretion of aldosterone, and basically it excretes excess sodium. So you essentially are dumping your excess sodium in the urine stream. That's natriuresis. And so they're excreted. And then as the sodiums are excreted in the urine, guess what? Water chases salt, right? So the water will chase that salt right into the urine stream, and that lowers your blood pressure. So that's what's happening here. So when your high blood pressure, when your high sodium kicks in, your ANH, your heart is going to secrete ANH, which is going to allow for the excretion of salt and water. That's going to bring your blood pressure back down to homeostatic norms. If your blood pressure drops, your kidneys will secrete renin into the system, which will then create angiotensin 1 and 2. Angiotensin 1 and 2 will then secrete aldosterone, which will retain sodium, which will retain water because water chases salt. And then the water will go back into your blood, increasing your blood pressure and bring your blood pressure back up. Okay. Now, sex steroids. So in addition to the glucocorticoids, the zona fasciculata and the zona reticularis secrete small amounts of sex hormones called gonadotropins. Oftentimes we think of these as androgens, which are the male sex hormones, and of course the female sex hormones are the estrogens. So the primary androgen is DHEA, which is dihydroepiandrosterone. This is the precursor to testosterone. That is the male sex hormone. So this happens in both male and female. So females also produce testosterone from their adrenal glands. That's what gives them their sex drive. And males, of course, secrete from their adrenal glands and also from their testes. So the gonadotropins. So then when you take a look at estrogen, you have small amounts of what's called estradiol, which is a form of estrogen. In females, most of the estrogen is coming off of the ovaries. And so the adrenal estradiol does play a little bit of a role in skeletal growth and things like that, in puberty, and bone mass. But most of that is coming from the ovaries. Now, what happens if your adrenal glands or your adrenal cortex malfunctions? Well, that's where we get to Addison's disease. This is the disease that President Kennedy had. This is a hyposecretion or a low secretion of glucocorticoids. Essentially, you have ACTH, but it's ineffective. And so it'll cause a bronzing of the skin, kind of a buildup of melanin. Kennedy had that. And then without the glucocorticoids, so your glucose can't be replaced in a stressful situation. And so what happens is you can have a situation where just a small infection can be a death sentence because you can't have normal glucose balance in your body. Also, if you have hyposecretion of aldosterone, that can really start to screw up your blood pressure and your water-salt balance. So this is kind of what Addison's disease looks like. So the different kinds of presentations of their effect on the skeletal system and sort of the hand development. So you can see the bronzing effect of the hand and kind of the nature of what it looks like. So Cushing's is basically an oversecretion of glucocorticoids. This is basically a situation where most likely you've got a tumor, either in the pituitary or in the area where ACTH is secreted or the adrenal gland itself, depending on where it is. But it's basically fouling up the communication piece of it. And so what happens is so basically what happens is you have a kind of a foul up in the normal communication of this. So you're creating abnormal levels of metabolic rates. For instance, your protein muscle will start to be broken down, and the fat will start to be deposited in your midsection. So the combination of the two is bad because you don't want to break down your muscle. That means muscle atrophy along with fat deposition. So you have more weight, but less musculature to support that weight. So an excess production of the adrenal gland, the male sex hormone in the adrenal gland, may masculinize females, increase body hair, deepening of the voice, things like that. And so the reduction of cortisone can oftentimes be used in order to treat this, right? Or cortisol inhibiting drugs, surgery to remove the tumor, depending on where it is and how that looks. So there's different ways to approach this if you do have this. So let's go ahead and take a look at the pancreas. Now, the pancreas is another organ, right? This is behind the stomach, near the duodenum, part of the digestive system. It's got both exocrine and endocrine functions. The exocrine tissue basically secretes digestive enzymes as part of the digestive system. The endocrine piece is typically coming off small little areas of the pancreas called pancreatic islets or islets of Langerhans. And so there's a couple of different cell types in here. So you have what's called alpha cells or A cells. These guys are responsible for secreting glucagon. I remember that because there's an A in glucagon that matches the cell type. The B cells or the beta cells are the ones secreting insulin. And then the D cells are basically secreting a type of somatostatin, which helps to regulate digestive processes. So somatostatin is a type of growth hormone that kind of regulates the development of these cells and the functionality of these cells. So when you take a look at some of the major secretions of the pancreas, like for instance, insulin, this is going to be one of the big ones, right? So this is not under pituitary control. Insulin is under pancreatic control. So it responds directly to changes in your blood glucose levels. And so for instance, when your blood glucose levels are high, you secrete insulin in order to bring those blood glucose levels back down. So what insulin will do is it'll tell different cells to essentially take up glucose, especially liver cells, muscle cells, and adipose cells. And so as the cells take up insulin, or excuse me, as the cells take up glucose, it lowers the blood glucose levels back down to normal homeostatic levels. So that's kind of what it looks like. So after eating, you have a lot of blood glucose in your cells. Your pancreatic islets, or the islets of Langerhans, is actually what they look like. So an actual micrograph of the islets of Langerhans, or at least a cartoon of what a micrograph looks like. It's pretty close. So these guys will start to produce insulin. They'll dump that into the bloodstream, and the insulin will then travel to the liver for the liver to take up the glucose and store it in a long-term storage form of glycogen. It'll tell muscles to also store it as glycogen or to use it. And of course, if you can't use it, it'll store it in fat so that you have long-term storage. So short-term storage and long-term storage, or you can use it if you're burning it. So when you take a look then at your levels, like for instance, if your blood glucose level goes down, then what's going to happen is that's going to trigger your pancreas to basically secrete a different type of hormone from the A cells, from the alpha cells. That's glucagon is going to be produced. Those are going to go into the bloodstream, and it's going to basically tell adipose tissue to start breaking down fat and release the glucose into your bloodstream, which will bring your blood glucose levels back up. It'll also instruct the liver cells to break down glycogen and release the glucose into the bloodstream, which will bring your blood glucose levels back up and get it back into homeostatic norm. So you can see how basically you have processes to kind of basically move these things in both directions. So the glucagon basically is always going to be secreted when the blood glucose levels are low. So your liver then will be instructed by glucagon to break down glycogen and turn that into glucose, so it goes into the bloodstream. It also will tell fat and protein to basically break itself down into glucose as an energy source, filling your blood with glucose, bringing that back up. And then it will raise your blood glucose levels. So basically what you have is a homeostatic curve. So if you take another homeostatic curve like I had before, in this case you have your glucose levels over here. What's going to happen is you have a normal oscillation of blood glucose that's peaking and troughing and peaking and troughing and peaking and troughing. And so at the peak, you have your insulin response, and at the trough, you have your glucagon response. So in diabetes mellitus, or diabetes mellitus, you have basically an excess of blood glucose in your system. And so your blood glucose levels rise. And then essentially glucose along with water is going to be excreted in your urine, basically creating a sticky urine. But because you're excreting a lot of water as well, you're always going to be thirsty. So that sticky urine with a thirst and insatiable thirst, that's going to be a diabetic type of a thing. So constant hunger, weight loss, things like that. So your high blood glucose levels oftentimes will increase your blood pressure And that's due to osmosis, that imbalance of strong particles in your water, and that causes this water imbalance, and that kind of is what creates a little bit of this. So vision problems, because you have a swelling in the lens associated with this water imbalance, you can actually, if it's not treated, you can get lots of severe infections. You can get blood vessel damage, kidney failure, nerve destruction, heart attack, stroke. These are all things that can happen to you if you have uncontrolled diabetes, especially. So that's the reason why you want to make sure you keep track of that. So of course you have two different types of diabetes. You have type 1 and you have type 2. So type 1 is associated with the one that's essentially it's a juvenile diabetes. You're usually either born with this one, it's like congenital oftentimes, or it's acquired early in childhood. It's what's referred to as insulin dependent diabetes. Type 2 is adult onset typically, or non-insulin dependent diabetes. And so the causes are a little bit different, but they can occur in either children or adults. In type 1, it's basically when the pancreas is not producing enough insulin in order to do the job. And so oftentimes this can be caused by either sort of exposure to an environmental agent, or maybe like a viral infection, or oftentimes an autoimmune response, which destroys and kills the pancreatic islets. Those are all causes of type 1, but you get it early in life. It's either, it's either exposure, acquired, or you can sort of be predisposed to it. Like, for instance, if you have a genetic autoimmune predisposition, that could cause problems. So in this case, what happens is a lot of times is the body will metabolize fat in order to kind of compensate, and that'll lead to the buildup of what's called ketones in the blood, giving you ketoacidosis. And so this will increase the acidity of the blood. Remember, your blood pH is normally around 7.4, so this will start to drop down to 7.2. This could lead to coma or death, and that's the reason why you don't want to mess with diabetes when you get it treated. So generally speaking, if you have type 1, you're injecting insulin daily. And so your blood sugars can swing from hypoglycemia, which is low blood sugar, to hyperglycemia, which is high blood sugar. And so the symptoms for both of them would be like shallow breathing, anxiety, perspiration. Hypoglycemia is easy enough to treat. You just basically have to ingest some sugar, get some carbohydrate in you. Hyperglycemia is a little bit different. You got to treat that one with insulin. And so you're constantly having to sort of switch back and forth, trying not to take so much insulin that you basically give yourself you just wipe out all of your blood glucose, but at the same time, enough to basically process it. So when you're talking about blood glucose management, it's a little bit of a balance, right? So you're always trying not to induce hypoglycemia, but you're trying to avoid hyperglycemia. So in a type 2 individual, this is basically a situation where oftentimes a patient is overweight or obese. It's oftentimes associated with the pickup of weight produces, and the fat cells essentially produces substances. They kind of start to dull or impair insulin receptor function. So the receptors actually associated with the uptake of insulin from normal cells is going to be compromised. And oftentimes that is what creates a problem. So you get insulin insensitivity sometimes in these cases. So that is to say the cells no longer listen to the insulin. So it can be more prevalent in certain families of ethnic, like for instance, the almost 3/4 more common in an African American population as opposed to non-Hispanic whites. But if your family members had it, then there's a greater likelihood that you would have it. So it is kind of a familial thing, possibly, as well. And so oftentimes the cells become insulin insensitive or resistant. And so the way to control this one is typically by going on a very strict diet, exercising regular, getting rid of that fat, trying to reawaken that sensitivity. If it fails, then you'll have to start taking drugs. And so a lot of people have type 2 diabetes without even knowing it. So they don't even realize it, and it's unaffected. So that's the reason why you want to go to your doctor and have your glucose test done with your your annual physical. Have that done routinely and have that glucose number checked to make sure that your doctors are keeping track of that so you can catch that early on. And so when you take a look at untreated type 2, it's as serious as untreated type 1. So you could drop into a coma and die. And so these are things you want to make sure you watch out for. So one of the ways to test for diabetes is by using an oral glucose tolerance test. Basically what happens is you feed a bolus of glucose to a patient. And then what happens is you take blood tests like every hour for like 3 hours, and you're testing for blood glucose concentration over time. And the idea is you're going to have a high blood glucose hit initially, but you want to see your body start to clear this glucose out of the bloodstream. You want to see that blood glucose level start to go down as your body is normally responding to this high blood glucose challenge. If you're diabetic, the blood glucose levels rise, they really fast and great, and they remain elevated for several hours. That is to say, you don't clear it. Out of the blood. And a non-diabetic person, eventually those levels will rise, but then they'll start to readjust after a few hours. So this is kind of what it looks like. So in this particular case, the light blue is a non-diabetic, the purple is a diabetic. So when you give them the glucose challenge, then you measure them for 3 hours, taking a blood test at every hour. And then what you're going to see is in a normal person, you're going to see a spike in blood glucose, but then you should start to see a tapering off and a kind of return back to normal within a few hours. In a person with diabetes, what's going to happen is they're going to have a much more dramatic glucose hit. So they're going to get much higher in their glucose, and they're going to have a much harder problem getting back down to normal. They were probably never really normal to begin with because their fasting blood glucose is over 100. So this kind of gives a doctor an idea of how the body is processing that blood glucose, and so they can instruct their patients accordingly. So there's some other endocrine glands. So we're going to be kind of finishing up, rounding out the end here with some cleanup ideas here. So we have basically the gonads, which are the male testes, female ovaries. So these guys will produce hormones that are associated and part of the endocrine gland. In addition, for instance, the thymus and the pineal gland as well are other tissues in the body that have endocrine functions as well. If you take a look at the testes and ovaries, so these are going to be controlled by the hypothalamus and also by the pituitary. So for instance, the testes are going to be located in the scrotal sac of the males, which are external to the body. The ovaries are located in the pelvic cavity of the female. The testes will produce androgens, which is essentially the male sex hormone or testosterone. Females will produce the estrogens or progesterone. Both from the ovaries are going to be produced from the ovaries. So those are both of them, estrogen and progesterone. Now, the testosterone, estrogen, and progesterone will basically feed back to control the hypothalamus secretions. For instance, the hypothalamus will control the testosterone, estrogen, progesterone producing with gonadotropin-releasing hormone, or GnRH. And so what will happen is the pituitary gland will secrete a couple of hormones, follicle-stimulating hormone and, of course, luteinizing hormone, and the gonadotropic hormones. And this is basically controlled by the feedback from the sex hormones, which are basically kind of feedback and sort of inhibit their own production. That's kind of what it looks like. So normally what you're going to have is you're going to have the production of the pituitary creating FSH and LH going to the female, or excuse me, going to the male testes in this particular case, which is going to be producing testosterone. And the testosterone will then either go back to reinforce its production, or it will go back and either reinforce or shut down its production at the hypothalamic point and also at the pituitary point. Typically, this is going to be a reinforcement because generally speaking, you don't shut down the testosterone. The testosterone is constantly being made. Same thing is also true for females, right? FSH and luteinizing hormone will be going to the ovaries, where the ovaries will be making progesterone and estrogen. Both of those will basically have the effect of reinforcing the pituitary and also the hypothalamus to basically maintain this kind of fertile cycle where you constantly have the production and the stimulation of the sex cell production. So that is the sperm and the eggs. So ultimately then what happens is at the testes, at the starting of puberty, what happens is we go from adrenal gonadotropic hormones to reproductive. So the testes, for instance, will begin to release large amounts of testosterone. This is what creates male puberty. And so that body, and it'll basically stimulate the growth of the body, of the penis, the testes, the secondary sex characteristics, right? So basically the facial, axillary, and pubic hair production, the larynx and the vocal cords will start to largen, thicken, and deepen. It stimulates the oils and sweat glands basically to start producing, and it also can cause baldness as well. So anabolic steroids, which is basically an artificial testosterone, it's made of testosterone, and it affects estrogen and progesterone. So estrogen, which is secreted at puberty, stimulates the growth of the uterus and the vagina in the female, and it's also necessary for egg maturation and egg production. So this is basically what's happening in the female at puberty. It's also the navigator, the driver of the female secondary sex characteristics, including body hair, the distribution of fat, more fat under the skin, the pelvic girdle widens, and of course the breasts mature, and of course your monthly menstruation. All of these basically are female sex characteristics that are being driven by the increase in production of estrogen at puberty. Now, anabolic steroids, which are basically a testosterone type, is going to be mimicking testosterone. So that's the reason why it has an androgenic type of presentation in individuals. The thymus, which is typically right below the sternum, reaches its largest size in childhood. As we get older, the organ gets smaller and becomes fatty. So it becomes basically the fat on top of the heart. Its job is to secrete thymosins, and the thymosins' job is to mature the lymphocytes. And so ultimately, as the lymphocytes move from the bone marrow, they pass through the thymus, they're transformed into T-cell lymphocytes where we store them for later immune response. Now, the pineal gland is going to be responsible for, it's on the opposite side of the brain from the pituitary. It's going to be responsible for producing the hormone melatonin, which is active mostly primarily at night. And so this regulates our daily sleep-wake cycle. For instance, one of the reasons why we get drowsy at night is because of melatonin levels increase. It's photosensitive. So as the lights go down, melatonin goes up, and it basically makes us drowsy. And then it's also the reason why we wake up when the lights come on, because basically the melatonin levels go down, and then we basically are alert. It also has an impact on the circadian rhythms, which is basically our 24-hour cycle. This is basically what's called our diurnal pattern. So basically, we are alert during the day, we sleep during the night, as opposed to the opposite, right, which is nocturnal, which is an organism or an animal that's alert during the night and sleeps during the day. So our circadian rhythms are governed in part by your pineal gland in response to and controlled by, in collaboration with the hypothalamus as well. It also can regulate sexual development as well. So there's a lot of things going on with the pineal. So for instance, when you take a look at melanin production, like the seasonal affective disorder, right, SAD, some of us have that, right, as basically when you take a look at different melanin productions, you can see your day-night cycles where you have your melanin increasing dramatically during the night, and then it'll come down, and it'll basically come down when it rolls into daytime. In the winter, you have a much broader night cycle versus the summer, which is a much shorter because your days are longer. So you have a much greater night cycle or a melanin cycle in the winter because the days are shorter. So that's your seasonal effect. So other types of hormones. We have erythropoietin, which we talked about before. Kidneys for the purpose of stimulating red blood cell production. So we already talked about that one before. I don't want to recapitulate that. And so that's one important thing. We have leptin, which is produced by adipose tissue. This basically will interact with the hypothalamus, and this will give you signals of fullness. So this is actually where your fullness comes from. So for instance, if you have a lot of weight, then this could dysregulate this sense of fullness, and so they don't have enough receptors to sense this, so they kind of disrupt their normal fullness, and that leads to overeating. Prostaglandins basically are made from a molecule called arachidonate, which is a fatty acid. They're local producers, they typically come out with damaged tissues, so they cause pain. So these are pain causers. And so it's usually isolated to just very specific situations. For instance, when the uterus is contracting, causes muscles to contract, that creates cramps. So that's prostaglandins kicking in. It causes fevers, so it's a pyrogen. So it basically increases the body of your heat. Gastric secretions and reflux can be caused by prostaglandins. Hypertension, that can lower your blood pressure. It can also interact with normal blood clotting and so forth. So prostaglandins are kind of a little bit everywhere. You see them involved in a lot of different places. So when you take a look then at homeostasis, and this is kind of like the blab slides for all of this, you can see how this basically interacts with the other system. So the nervous system, basically you're interacting with your external environment because the information is coming in from your external environment. Your CNS, your central nervous system, will integrate that information and decides the proper course of action, to which sometimes that's going to be moving through the body as an endocrine response. The endocrine basically and the nervous system work together in reflex actions, especially in the hypothalamus, as it's connected to the medulla oblongata to control blood pressure. So for instance, aldosterone, which is acting at the kidneys, will retain sodium, and thereby, because water chases salt, will also retain water. The antidiuretic hormone basically promotes the water absorption in the kidneys, and that basically controls the blood pressure. So ultimately, the reproductive system can't function without the nervous system, because ultimately the hypothalamus controls the anterior pituitary, and the anterior pituitary is the one that's sending the hormone to the testes and the ovaries for the production of gametes, right? So for instance, these guys are the ones sending the follicle stimulating hormone and the luteinizing hormone. And they can also basically control the contractions associated with the ducts that propel the sperm. And so these will all be then tied into as well when you take a look at the positive feedback loop with oxytocin during birth, right? So that's interacting all with your reproductive system. So when you take a look at your neuroendocrine system, right, this is kind of like a confluence between the nervous system and the way the nervous system and the endocrine system work together, right? You have a combination of two systems where basically your hypothalamus bridges the regulatory cavities between the nervous and the endocrine, because it's got to half and half, right? So it basically has nerves that actually act on the autonomic nervous system, but at the same time, it also has the endocrine piece where it acts through the pituitary gland. And so the hypothalamus actually can be thought of sort of as dual citizenship in both the nervous system and the endocrine system, and oftentimes is referred to as the endocrine organ. And so when you take a look at that, then you can see how basically everything is tied together with the endocrine system, because the endocrine system is basically regulating all systems in your body. So it's regulating the urinary system through the RAS system and water blood pressure balance, your digestive system, which is being regulated through hormones associated with digestion, your muscular system, which is being regulated, especially when it comes to androgens, which is the growth and regulation of skeletal muscle, and also muscle growth and bone growth. Cardiovascular system, which is basically being regulated, associated with, like, for instance, things like your fight or flight response with the adrenal glands and things of that nature. Your respiratory system is being controlled and regulated because basically these are the ones carrying gas exchange, so oxygen and CO2. And so these guys are necessary for regulation along with that cardiovascular system. So you have both nervous and endocrine systems. So for instance, the adrenaline will affect the respiratory system, your reproductive system certainly is highly endocrine in nature. It mostly controls hormones actually. And of course your integument system, which has basically a lot of growth hormones associated with the growth, development, repair, and wound repair of your skin cells. Okay, so that is the lump sum of the endocrine system, chapter 16.